guide the management of the patient. The reasons for increased use of imaging in pregnant women is multifold. One of them is that more and more women with comorbidities are getting pregnant. Also, the increased maternal age and previous surgeries and other comorbidities, they are now getting pregnant and are being managed as high risk cases. So, with the background of high risk pregnancy, the clinicians and the patient are clearly more anxious to do the right thing. One, for the patient, we don't want to do something that's not right for the patient. It's always in the patient's best interest, but also because whether we deny it or not, we are living in more and more a medical legal world. We may call it defensive practice, but the other way I would look at it is that we are using the tools we have to make the best decisions for our patients in the best interest of the patient. So the twofold factors have led to an increase in using imaging, especially cross-sectional imaging in pregnant women. Um, why why is it more challenging in pregnant women? Because there is an altered physiology, and so the pathophysiology is of common conditions is altered. The imaging findings are not typical of what you would expect in a non-pregnant patient. So we're going to look at some imaging findings in acute non-obstetric abdominal conditions. And as radiologists, we have a duty to know the merits and limitations of the imaging modalities we use and use them judiciously to guide the management of the patient. So a quick slide about the prevalence of acute abdominal conditions in pregnancy.
Can
As in the
you
non-pregnant population, appendicitis remains the most common cause of abdominal pain.
please, ma'am?
Gallbladder disease and pancreatitis, usually due to gallstones, remains a common cause as well. Bowel obstruction is rare, 1 in 3,000 pregnancies, but obviously, with more women having surgeries or inflammatory bowel disease, the incidence is slowly going up. Although we do worry about ovarian torsion, as you can see, it's the least common cause of surgical intervention in pregnancy. And despite, we do a lot of imaging, and I don't think it's because we are not picking it up. I think it's just that it is rare in pregnant women. So, why is it challenging for the clinicians? Because there is a change in the anatomy and the physiology. So, the abdominal viscera are displaced, so it is difficult to localize pain. For example, your typical appendicitis patient will not present with pain in the right iliac fossa. They may present with right upper quadrant pain, depending on how the bowel has been displaced by the gravid uterus. Clinical examination is more difficult. And also, there are other conditions or other uh, changes in the physiology which affect how the woman presents. So elevated progesterone not only causes an increased appetite, but also because of smooth muscle relaxation, there is a reduced transit time um, of the bowel contents, which is a normal physiological change. Again, because of that, there is increased risk of reflux and heartburn and a delayed gastric emptying. These are things which our anesthetic colleagues keep in mind more often because of risk of aspiration during anesthesia. Ureteric compression is well known, but in some women, as a consequence of that, there is urinary stasis and it predisposes them to infections and renal calculi. What are the risks of misdiagnosis? There are a few things we need to bear in mind here. Like I said, there is leukocytosis, alkalosis, hypocapnia, increased respiratory rate. So
Ma'am, can
these
you
are
hear
all
me? Excuse me,
normal
ma'am.
physiological
Yes,
conditions, and sometimes it becomes difficult to diagnose or change, find out what is actually the pathology and what is due to pregnancy. Again, there are other obstetric complications which also have to be borne in mind. But our aim is to look at to make sure that the women who need surgical intervention or some sort of intervention get it, and the women who don't need it are saved from
Uh, Good evening, everyone. Sorry for the technical glitch. We are just trying to sort this out. Please hang around for a couple of minutes.
I just removed the speaker, so it's just the laptop. I don't know what happened there. I'm sorry, I'll start again.
Yeah, thank you so much. And thank
Um,
you all the more than 200 participants who stayed back and joined again. We are sorry for the technical glitch and we are up and running now. Hope you have a great time ahead. Thank you, ma'am.
okay, thank you, and I'm sorry about this. So we'll start again. So this is, I think this is where there was a problem. Um, so this is just a slide on the prevalence of acute abdominal conditions in pregnancy. As in the non-pregnant population, appendicitis is the most common, with gallbladder disease and pancreatitis, usually secondary to gallstones being the common one. Bowel obstruction, although was rare, is becoming more frequent because of more women with previous surgeries or high risk getting pregnant. And there is, sorry, just give me 1 second. Yeah.
Ma'am, can
And
you make it
also,
full screen, please? It's
can you
still,
hear me now?
yeah, I can hear. We can hear you. Can you just make it in the presenter view? Uh,
Uh,
uh, Full screen, maybe at the bottom of just next to the Zoom thing. Yes, ma'am. I think the right of, to the bottom right. Or
sorry.
yes, ma'am. To the bottom right corner, you will find the option of full screen. Uh,
Ovarian torsion and head neck lesions are actually, torsion due to head neck lesions is actually quite uncommon. Why is it, why are we doing more imaging, or why is clinical diagnosis difficult? It's because the
Ma'am, sorry, the slides are not moving again. We're stuck on the first slide.
uh,
Are you using a dual screen? Is it a dual screen computer?
no, it's not.
Okay. Um, can you
Just
scroll to the fourth slide?
no,
Yes.
1 second. I think I'll change.
Yeah, now we can. Yeah, now we can. Great.
Okay, I'm so sorry about this. Um, but yeah, so going back to why clinical presentation is challenging, it's because there is displacement of the organs by the gravid uterus. So your appendicitis would not present with right iliac fossa pain. They may present with right upper quadrant pain. It is difficult to localize pain due to the altered anatomy. And again, clinical examination once in second and third trimesters becomes more difficult, with the gravid uterus occupying most of the abdomen. What are the physiological changes that happen? There is elevated progesterone, which decreases the lower esophageal sphincter. So there is increased reflux and heartburn. There is delayed gastric emptying, and also the general transit of the contents through the bowel is slowed down. So there is not only delayed gastric emptying, increased
prevalence of things like constipation. So we can't rely on the usual parameters that we use completely. Although I'm not saying that it's impossible, but it's more challenging. Again, we know that the ureters are compressed, and so the women are at increased risk of UTIs and renal calculi because of the compression by the gravid uterus. What are the challenges, or why should we not misdiagnose? Because there is increased risk in misdiagnosis, such as, pregnant women normally have alkalosis, hypocapnia, and increased respiratory rate, and leukocytosis. So it's finding where the balance between the altered physiology in pregnancy has moved into pathophysiology. Again, if there is untreated abdominal conditions, there is increased maternal and fetal mortality and morbidity, not to say the increased risk of preterm labor and challenging surgery in pregnancy. So it is important to diagnose at the right time, but also not unnecessarily intervene in the pregnant woman. This goes for everyone, but I think the risks and it's more challenging with pregnant women. So, and of course, there is the increased risk of anesthesia both to the mother and to the fetus. We're all worried about fetal radiation exposure. I wouldn't say we have never done a CT. I think I have seen one case in my career where we had to do a CT because the patient was so high risk for bowel complications. But in general, we all would like to avoid fetal and maternal radiation exposure, as well as we have to bear in mind increased radiosensitivity of the breast during the later stages of the pregnancy. We use MRI as the preferred cross-sectional modality, but the long-term effects of the strong magnetic field on fetal development is still unknown. Again, risk of gadolinium exposure to the fetus. Again, we don't have very strong data. We don't have anything to say yet that there may be harmful, but we just don't have enough data, long-term data, to talk about the absolute safety of these um, interventions. And as the woman's pregnancy progresses, there is the difficulty where the patient cannot tolerate prolonged imaging. What are the imaging modalities we use? As always, ultrasound is the first. There is no radiation, it's cheap, it's portable, and easily available. When done by the right person, it provides extremely valuable information, not just about the conditions. Also, it's a dynamic test. So, bowel motility, tenderness where the patient is tender, or these are all things that add up to us providing a diagnosis to the clinicians. And if need be, the fetus can be assessed simultaneously. If the woman needs percutaneous intervention, then ultrasound is the modality of choice. And yeah, the limitations, as with any other woman, is the body habitus, where there is a displacement of the organs by gravid uterus. So that's one. The woman body habitus may limit visualization, and again, inability of the patient to lie flat for prolonged examination. So this is a limitation for all the modalities, but with ultrasound, sometimes we can, take a break, ask the woman to lie on her left lateral side or put the bed up. It's not ideal, but at least we can do some modifications to help. So if the ultrasound doesn't give us the answer, then we go on to MRI. So, what is the protocol we use? MRI sequences, they are tailored to the clinical question, the stage of the pregnancy, and the ability of the patient to tolerate MRI. In our institution, it is almost always supervised by an abdominal radiologist, and we start with the basic sequences, which are T2 haste, axial and coronal, T2 axial fat saturated images, and we use the 1.5 Tesla as a preference to reduce the magnetic field. The T1 weighted and diffusion are added if required, and we've almost never used gadolinium or general anesthesia for the MRI. And the rationale being, if the woman needs a general anesthesia, um, it's probably better. I mean, if she's that unwell that she needs a GA for the MR, she might as well have a surgeon directly look and see what's happening and treat it at the same time. There's no point in having two GAs, one for the MR and one for any potential surgical intervention. So this is the sequences that we use. We start with the T2 haste and fat saturated, and then our radiographers call us at this point. We see what we can see on these sequences, and then add in sequences as and when required. So T1 axial is useful for anatomy and for hemorrhage, and if there is any area that we are concerned about, then we ask them to do a high resolution TSC through the area of concern. Very rarely have we used diffusion weighted imaging. It doesn't really add much. I know we sometimes thinks it helps between pus and fluid, but we have other ancillary features on the T2 and T1 weighted imaging which would help us make the decision. So only if necessary, then we do the diffusion. We try to keep the examination simple. We As long as we can answer the question, or at least give the answer that there isn't really much significant going on. The We are very clear with the clinicians that we are not here to give you the diagnosis every time, but we can give you enough information to say that, well, we can manage this conservatively, or no, the patient needs surgery. There is just to bifurcate into those. The clinicians are aware, and we work closely with the obstetricians and surgeons to um, discussing the scans, and then we proceed with the MRI. Because we know that there are a few limitations on the safety. We have a few small studies which did not really show any increased risk of stillbirth or congenital malformations or hearing loss in the fetus, but rare adverse outcomes cannot be detected because it's a small size study. On the same study, there was a slightly increased risk of rheumatological inflammatory conditions in the child who were exposed to gadolinium. Most of the patients in the study were those who had gadolinium either because they did not declare the pregnancy or they didn't know they were pregnant. Very few of them actually received gadolinium with an intention of knowing that the patient was pregnant. So I'll now move on to the cases. I've got a few cases which will demonstrate some of the points that I was trying to make. So the first is a 31-year-old lady who was 20 weeks pregnant. She was admitted with vomiting and abdominal pain. She had a significant past medical history of a colectomy and an ileoanal pouch for ulcerative colitis. She had raised inflammatory markers and also, confusingly, slightly raised amylase. Um, was it colitis, or was it something more that needed intervention? Was the question. So initially she was managed conservatively. Ultrasound was normal, but she did not get better. So an MRI was performed 3 days later. So this is a screenshot of the T2 haste coronal, and the T2 axial is playing. I'll just play this again so we can look at the images. So there are dilated small bowel loops and a collapsed loop towards the ileoanal pouch. There is an abrupt transition point, and the diagnosis here was small bowel obstruction. We don't know the cause, but there is enough there to justify surgical intervention in a patient who's not getting better with conservative management. So she had a laparotomy, and a descialisis was performed, along with which relieved the obstruction. So again, it's a guide to appropriate intervention when there is high risk features like this woman who had previous surgeries, and also when we have to justify giving general anesthesia. So the second case is someone who was more further along in the pregnancy with an acute abdomen and raised inflammatory markers. She really could not tolerate the examination, so we have very limited sequences. I think we just had T2 coronal axial and one fat saturated sequence. I'll let the videos play, and I'll replay them once more so we can have a look. So we can all see the dilated loops of bowel, but in the left lower quadrant, if we focus, there is a thick walled collection and there is a blind ending tubular structure very close to it. So just there, that's the collection, and a blind ending inflamed looking tubular structure. There's nothing in the right iliac fossa, and there was no evidence to suggest there was malrotation or anything like that. So we told the surgeons that look, there is a collection and there is this tubular inflamed structure. Um, we're not sure what it is. She also has a reduced corticomedullary differentiation in the right kidney, so pyelonephritis is also within the differential. But she was very tender on the left. Inflammatory markers were through the roof, so they decided to operate on her. And surprisingly, um, there was a small bowel obstruction secondary to a perforated Meckel's diverticulum. So this is we will not be able to diagnose, or it would be very challenging to say that this is due to Meckel's diverticulum, but we had enough information to tell them that there is bowel obstruction, there is a collection, and we cannot take this further on imaging. So with this information, it was justified in this unwell patient to go for a laparotomy. The surgeon knew what to look for and what to expect, and it helps. We are here to provide a roadmap, a guidance to the surgeon or the clinical team, and it's like giving them a guide map to go and see what is actually going on, reduce surprises that they may encounter during surgery. So although there was limited sequences, we still got some useful information. The third case is, this is very straightforward. 12 weeks pregnant, right iliac fossa pain, raised inflammatory markers, clinically appendicitis, but she had high risk features for anesthesia. So the surgeons wanted to be absolutely sure. Also, she was in severe pain, so it was also to exclude that there wasn't anything else going on. Although they suspected appendicitis clinically, we decided that she needed an MR before she went for surgery. So this is quite straightforward. I'm not going to replay the video because we can all spot the inflammatory changes in the right iliac fossa with a dilated, inflamed looking appendix and an appendicolith in this pregnant woman. So this was uncomplicated appendicitis, and she had a laparotomy, went home, recovered, and went home. The interesting thing was that when we look back on the Scout localizer images, we could see the inflamed appendix with and the changes. So it is just to drive home the point that whatever limited sequences you have, it just have a look. Sometimes even just the Scout can give you useful information. We don't need a very elaborate protocol or a very long time on the scanner. Although we may not make a definitive diagnosis, we have enough information to guide the patient's management. The next case is a lady who was 34 weeks pregnant and admitted with diarrhea, pain, and was treated for sepsis. As a part of the septic screen, she had blood cultures which was positive for Aconella. which is a gram-negative organism and is frequently seen with intra-abdominal collections. So the microbiologist uh, suggested that she have some sort of imaging to rule out collections. Ultrasound did not really pick up much, so she went on to have this MRI. Again, as you can see, a very gravid uterus, so very limited sequences. I'll just play this again so we can see the collection in the right iliac fossa with a tubular structure just adjacent to this. Just there. And so this was a perforated appendix with a collection on the right side. Um, with this patient, the surgeon felt that in the advanced stages, it's probably not advisable. So we decided to try percutaneous drainage first. And the collection was drained under under ultrasound guidance because she recovered and then she was asymptomatic. They did not do an appendicectomy. Uh, she went home, carried to full term, and the, did not need a surgical intervention. So this is where one MRI guided the. We had a diagnosis. We knew what to do. Also, the benefits of ultrasound guided intervention as an alternative if invasive surgery and GA can be avoided. So this lady was 21 weeks pregnant with history of previous pancreatitis, came in with what looked like pancreatitis, but on ultrasound there was a cystic abnormality in the pancreas. So we wanted to rule out any acute complications of pancreatitis and also to see if there was any collection that needed drainage. So I'll just let you look through the MR videos. So we can see the inflammatory changes around the pancreas, confirming pancreatitis, but also the cystic lesion does not have any high-risk features or it doesn't look inflamed or like a collection that needs drainage. So there was no need for intervention. She was managed conservatively and the cyst was followed up on ultrasound. It remained stable and after the pregnancy, when she had a MRI, it just showed that it was stable and did not have any features of IPMN or any other cystic lesion. So it was diagnosed as a pseudocyst, and she had acute and chronic pancreatitis. So we avoided intervention or drainage. Again, it's where we've done the best thing for the patient and avoided any unnecessary intervention. This is the last case. This lady who was 19 weeks pregnant and presented with right iliac fossa and right loin pain, septic, and it was whether this is acute appendicitis or acute pyelonephritis. So she had an ultrasound which showed this subcapsular collection, which was not, it was clear it wasn't simple fluid, and it was whether is this hemorrhage or is it an abscess was the question, although it did not look like hemorrhage and there was no real history of trauma. Um, there was a slight drop in the hemoglobin, so I think the clinicians were concerned about a potential hemorrhage or a hemorrhagic collection. So we did an MRI, and this is the T2 coronal. This is subcapsular collection with florid inflammatory changes on the right. And as you can see, there is some layering within the collection, within the abscess, the reactive pleural effusion. So, this. So it was, but with all the inflammatory changes, we thought this was a hemorrhagic collection. This was drained on ultrasound, and we then also could tell them that we can't see an cortical tumor or an angiomyolipoma. She was conservatively managed, drained. She responded to antibiotics, and we followed up kept following it up on ultrasound, and this was postpartum, which just shows complete resolution with a residual small cystic lesion. So, just to summarize what I think I've said and reaffirmed throughout is we have valuable diagnostic tools which can confirm or refute a diagnosis in pregnancy, justify or avoid procedures and general anesthesia, and close correlation with the clinical team, and where everyone is aware of the limitations, what we are looking for, and judicious selection of imaging and sequences in the MRI will most often give us the answers that we need and some references. Thank you.
Thank you so much, ma'am, for that amazing session after the technical glitch. I'm sure it was worth the wait for all those who stayed back. It was lovely to have you on this platform, and there are a couple of questions coming in. Uh, do you mind taking them?
No, no, not at all.
In the Q&A section, ma'am. So the first question is, do you comment on the fetus in report while performing MRI for acute abdomen in a pregnant lady?
I always add in that this fetus has not been assessed. It is to cover myself for medical legal purposes. I always add that please note the fetus has not been assessed on this MRI.
Okay, ma'am. Thank you. I don't see any other question coming in. Yes, apart from the technical glitch, I think it was lovely to have you on this platform, and it went very smooth later on. Thanks for staying back. And I think Destiny knew that the webinar is for half an hour, and so we could start at 7:30 also. It was lovely to have you on this platform, waiting for more such interesting topics from you in the near future. And hope you wouldn't mind joining us again in later in the
I
year.
No, I would be privileged, and I'm sorry for the technical glitch. I mean, I've rarely done Zoom after COVID. It's been a few years, so I think I'll just refresh my technical skills as well for the next time.
No, no, that's perfectly okay, ma'am. And thanks for doing it in spite of your ill health and the pharyngitis. I hope you recover pretty soon.
Thank you.
Thank you, ma'am. And with your permission, I'll end the webinar here.
Yes, please.
Yeah.
Thank you.